I'm Abe Morgentaler. I'm not really a prostate cancer guy, except I came in through the back door, if I can use that expression. I'm really a sexual medicine guy who's been working with testosterone for many years. And it's fantastic at a prostate cancer meeting to have a session in which we talk so much about testosterone, not only the age-old way of lowering it, but also thinking about the importance of testosterone deficiency or hypogonadism, and possibly with treating it. So the first question here in this first talk is really, is there a link, or what is the link between prostate cancer and testosterone? And I think some of this is clear. We all know that prostates, both benign and malignant, respond to androgen deprivation. That part is not in dispute. The part that's really come into question over the last 15 plus years is, does higher serum testosterone increase the rate of prostate cancer? Does higher serum testosterone increase the risk of worrisome prostate cancer, higher Gleason score or stage? And does higher serum testosterone impact outcomes? In the past, we just assumed the answer to all these questions was yes, but I'm going to show you some of the evidence around this now. So I'm 60 years old, and I just published a 40-year perspective on testosterone therapy. How does that work? Well, when I was an undergraduate at Harvard, I really was a lab rat, and manner of speaking, and worked for 3 years. I was going to be a biologist, working with the male lizard, Anolis carolinensis, which you see here. This is the male, this is the female. These are the little guys, about 4 to 5 inches, you see in Florida and in the Bahamas. They sometimes get in your hotel rooms. And if you put a male in with the female, he's got this bright colored flap of skin called a dewlap, and his head goes up and down very quickly. We call it a stuttering push-up. It's as if the male is going, yeah, 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 yeah. And the female, if her ovaries are intact, will do a very stately, elegant single push-up. The male comes closer, the dewlap comes out, yeah, 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 and then they do it a few times, and then they mate. If you castrate the male, which was my first procedure I ever did, bilateral orchiectomy in the male lizard, they're internal, by the way, near the kidneys, which makes sense embryologically, right? If you castrate the male, their testosterone essentially goes to nil, and you put them in a cage with a female after they've recovered, and they don't do anything. They don't care. They have no libido. The female will sometimes do her little push-up, like to say, hey, buddy, I'm over here, and the male does nothing. So we had known from previous experiments that if you put silastic pellets of testosterone under the skin, you could restore sexual behavior. But we were interested in the brain, and we had done studies where testosterone was taken up in the brain of these lizards. And my project was to actually take tiny amounts of crystalline testosterone, put it in the portions of the brain that we knew were related with sexual behavior and that had uptake of the hormone in our studies. And that was the medial preoptic area and the anterior hypothalamus. And if I had been successful in putting it in there, these castrated males in the cage with the female would extend their dewlap, yeah, 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 and they would mate. So it was an amazing thing, and circulating levels of testosterone were, again, undetectable. So what I got out of this at a very young age was that, number one, testosterone was a brain hormone, and number two, at least in the male lizard, it was necessary and sufficient for the entire range of sexual behavior. So I didn't learn too much more about testosterone through medical school. I knew that when I went to medical school, I knew that it was involved with virilization of the male fetus. I knew it was necessary for puberty in the boys. I knew it was involved with secondary sexual characteristics, Adam's apple, body hair, things like that, right? But that's pretty much all I knew about it. And then I went through 6 years of residency in urology and learned that if you lower testosterone, that's good treatment for men with advanced prostate cancer. But the idea of treating men with testosterone was something that was hardly done at all. And important to sort of understand the history of this, I think it's interesting. Testosterone was first synthesized in the 1930s. The two guys who developed it in 1935 each won the Nobel Prize together. But we didn't use much testosterone during my residency in the 1980s because we thought it was going to cause prostate cancer. And the only men who received testosterone in the 1980s were really three categories of men. Those who had congenital or genetic issues like Klinefelter's, men who'd had pituitary tumors which interfered with LH release, which again is what stimulates testosterone, or men who'd lost their testicles to cancer or trauma. And the big fear was if we give testosterone to these men, they may have cancer, it may grow, or it may cause cancer. And this was the view that I learned, and that all of you probably learned the same. Testosterone was essentially the devil when it came to prostate cancer. I learned that prostate cancer was caused by androgens. I learned that high testosterone caused rapid prostate cancer growth. I learned that low testosterone is protective, right? That eunuchs were never supposed to get prostate cancer. Any of you ever hear that? Of course you have. And that if a physician were foolish enough to give testosterone to a man with an existing cancer, it was like pouring gasoline on a fire or feeding a hungry tumor. Anybody ever use those expressions? We all have, right? I mean, I did too. I taught all my residents and medical students that for years. But because of my experience with the lizards, and I was doing sexual medicine, we didn't have much to treat these guys with, right? Cialis, Viagra, they weren't around. And I was just curious, and so I started checking testosterone levels in men when I came out of my training in '88, and I was surprised at how often the levels were low. And then I started treating these guys with what was then the standard treatment, which was an injection of testosterone cypionate every 4 weeks. And these guys came back and they said, "Doc, this is great. My libido's improved, my erections are better. I'm better in ways you never even told me might happen." Like what? Well, my wife says I'm nicer to be around. I have more patience for my kids. I wake up in the morning, I put my legs over the side of the bed, and I have a sense of optimism about my day. I thought that was interesting, but I thought maybe this is probably a placebo effect. So, because the guys knew they were getting the male hormone testosterone. But what convinced me this was real was that several of these first guys said to me, so that's how I feel for the first couple of weeks after the injection, but you're giving me an injection every 4 weeks, and for a week or two before my next injection, all my symptoms come back. What's up with that, doc? And I didn't know. So we checked hormone levels, and it turned out that the first 2 weeks levels are nice and elevated, testosterone, and with testosterone cypionate, every single guy was back to their baseline low levels of testosterone by 14 days. So there was no way the patients knew that. I didn't know it. It was a bad version of a double-blind experiment where the patient doesn't know and the doctor doesn't know. But what it said to me is that the men could tell when their levels were good and they could tell when they dropped, almost to the day. So this was real, and I started doing more and more of this work. And I thought it was interesting. It defied standard practice at the time because these men didn't have pituitary tumors. They didn't have Klinefelters. They had 2 testicles. And that was all pretty interesting, and I was excited, and I started doing more and more of this. But again, the big fear was prostate cancer. And we were finding out then, late 80s, early 1990s, that there was a lot of occult prostate cancer around, right? Remember all this stuff. The guys who were in studies, guys died in motor vehicle accidents, army studies, military ones. And so the fear was that if I was giving testosterone to these men, maybe I was doing a deal with the devil, that they may feel better now, but their prostate cancers were going to grow. Some of them must have it. And oh my God, maybe something bad was going to happen. So I started doing prostate biopsies in men who had low testosterone, who I thought were candidates for treatment. Even though their PSAs were normal, less than 4, and they had normal digital rectal exam, I wanted to make sure as best I could that they didn't have a hidden cancer that was going to grow like crazy, right? Gasoline on the fire. And remember back then that low testosterone was believed to be protective. These guys should have had a vanishingly low rate of prostate cancer. These are the days of sextant prostate biopsies. And in JAMA, 20 years ago now, we published what I think is really the first chink in the armor of the old story that high testosterone is bad, low testosterone is protective, because we found a lot of cancer in these men, a rate of 14%, that was really similar to men who are at risk because of high PSA. So this is a figure from the JAMA article. This was the rate of cancer in our men was 14%. This is a group of studies from around the same time of biopsies in men who had normal PSA less than 4, and that rate of cancer was between 0 and 4.5%. And then these are rates of cancer in men who either had an abnormal digital rectal exam, here's Dr. Stone's, here's one from Catalan, either abnormal digital rectal exam or abnormal PSA. And those rates here were between 13 and 20%. And I would suggest to you that this number looks more like these studies where there's a risk factor than these studies where they're not. And so the concern was actually maybe low testosterone biopsy, and these are sextant biopsy results. This is why these numbers are lower than what we might see today. So that was interesting. And so I no longer believed after that low testosterone was protective, and we've gone on and published another series in 345 men, and that number is important to keep in mind. If you put a needle into the prostates of men who have a PSA less than 4 but low testosterone, the chances are about 1 in 7 that they're going to have cancer you'll find on your biopsy. 1 out of 7. Now, I want to do a little thinking experiment with you. The rates of testosterone treatment have increased dramatically, right? It's like tenfold what it was back then. And yet, we don't have any epidemic of prostate cancer in men who are treated with testosterone. If 1 out of 7 men with a normal PSA but low T has prostate cancer, I don't know how many of you treat with testosterone, but if you treat any number of men at all, more than 7, there's a good chance you're treating some men who have prostate cancer with testosterone, and their prostate cancer is untreated. Frankly, it's undetected, right? You haven't biopsied them because their PSA is low. So I no longer believed that low testosterone was protective, but I still believed high testosterone was a problem until 2004, when we wrote this article that Neil was kind enough to show some of the references in his talk. This was on the risks of testosterone therapy, New England Journal, together with my fellow Renani Roden. Now, the timing of this is interesting, too. So the first branded popular testosterone product came out in the United States in 2001. That was the gel. I hope you don't mind if I use the brand name is just so you guys know what it was Androgel, and really changed things. 2002 was when the Women's Health Initiative came out, so there were concerns about hormone therapy in women. And so this is 2004, increasing sales of testosterone. Doctors for the first time are getting information. They're getting detailed about this from reps. So what are the risks of this therapy? And we focused a lot on prostate cancer. And Hernani was my fellow. He's now a very prominent urologist in Brazil and very confident young man. And we reviewed a few hundred articles, and we're ready to draft this manuscript. And Hernani comes to my office and he says, "Chief," he looks nervous, "do you have the articles that show that testosterone is bad for prostate cancer?" I said, "Hernani, I thought you had them." And what we found and published, 2004, is that the number of articles in the PSA era that showed something worrisome about testosterone therapy or just higher naturally occurring testosterone levels and prostate cancer, the number of articles we found was 0. It's not that there weren't articles. They just couldn't find it. And it's fascinating to go back now, and you read some of these articles. A lot of them are sort of by public health people, these large population studies. And in the conclusions, they say, we don't know why we didn't find this obvious relationship, but we didn't. And we suggest that future studies look at ABC. And then the next paper comes out and says, we looked at ABC. We don't know why we couldn't find the relationship. We suggest future studies look at XYZ. It wasn't there. So where did this idea come from? Because every medical student around the world was being taught that prostate cancer was related to testosterone levels. High testosterone was dangerous, low testosterone was protective. So Paul Lang, who many of you know, I was at a conference like this with him, and I gave a talk after we'd done that paper, and I said, we just can't find the evidence. And he said, Abe, your stuff is interesting, but you better be careful because maybe metastatic disease is different. Huggins wrote that it was, that testosterone was really bad. So in the days before you could just pull up any article on PubMed, you actually had to go to this strange institution called a library, and which is where I went to find the original article by Charles Huggins, 1941. Huggins, of course, won the Nobel Prize as the patron saint of urology. And I found his article down there in the stacks in Cantway Library. And I read this article, which, great title, it's a landmark article, The Effect of Castration of Estrogen and of Androgen Injection on Serum Phosphatases in Metastatic Carcinoma of the Prostate. This paper, number one, established acid phosphatase as the marker for metastatic disease. And number two, gave us the idea about androgens and number two, castration or its equivalent medical was effective for metastatic disease. And then the third is sort of an add-on in a way, which is that testosterone added to these men was dangerous. So I read through this paper, and Huggins writes with Hodges that every individual who they gave testosterone to had a rise in their acid phosphatase. And that, and by this time I'm treating a lot of men. And I remember that moment, my palms were sweaty. I think, oh my God, some of my patients are going to come back with terrible prostate cancer. Huggins said so. And in one of these moments where I forced, my heart's racing, I forced myself to reread this article. I say, how many men did he actually give testosterone to? And it turned out they'd only given it to 3 of these men with metastatic prostate cancer. In the results section, they only gave results for 2 men. One of these men had already been castrated before he got testosterone, and today we would call that a special case. We would say that man was androgen deprived. So in the end, the general rule that we all learned, and this is their quote, that cancer of the prostate is activated by testosterone injections, was based on only a single hormonally intact man who received testosterone for only 14 days, and his acid phosphatase curves goes up and down. It is uninterpretable. This is the basis for medical students around the world learning that testosterone injections or testosterone therapy was dangerous for prostate cancer. So, what does modern evidence show? This is a pooled data from 18 longitudinal studies, over 3,000 men with cancer, 6,000 age-matched controls. You see quintiles there for testosterone, free testosterone, DHT. There's no relationship between androgen concentrations and the development of prostate cancer. Specifically, men with the highest levels of testosterone or DHT or free testosterone are at no greater risk of developing cancer, prostate cancer, than men with the lowest levels. It's not there. The placebo arm of the reduced trial, remember the reduced trial with dutasteride, but this is the placebo arm. They received nothing. These guys had testosterone and DHT levels measured at baseline, and then as part of the study, they had biopsies mandatory at year 2 and year 4. What did it show? Prostate cancer risk was not associated with either serum T or DHT, and men with high testosterone, again, had no greater prostate cancer risk than men with low levels. Meta-analysis of 22 randomized controlled trials, over 2,000 men, no difference in prostate cancer rates for men who did or did not receive testosterone. So, the old idea that higher testosterone contributes to the development of prostate cancer is not supported by the current evidence. And if you look back historically where you got this from, it was actually based on the weakest of evidence and possibly misinterpretation of the author's own data. And so the question is, like, how does this all work then? We know that if we deprive men of androgens, there's important things that happen. Right? So we do androgen deprivation all the time with men with advanced disease, but there's studies of even giving LHRH agonists in men who are healthy, and what happens to their PSAs and their prostate volumes? They go down substantially, right? PSAs can become undetectable in healthy individuals, no cancer. Makes sense, really, right? Finasteride, dutasteride, they block the DHT part, not the T part, and PSAs go down by about half. There's clearly a relationship, but higher levels don't seem to be doing much of anything. So I think part of the answer comes from data like this. This is from a study in men really looking at muscle stuff, but what they're looking at here for safety is testosterone. These men were given an LHRH agonist, so they make none of their own testosterone, and then different groups were given different weekly doses of testosterone injections. 125 is really kind of replacement dose. We use 100, but consider this sort of normal. These are 2 lower doses, and these give you supraphysiologic testosterone levels. And if you look at the blue, which is testosterone, you can see that at the higher levels here, 1,000 is top level for normal. These guys here are more than twice the upper limit of normal, okay, for testosterone. At 20 weeks, 4.5 months, what's happened to PSA? It's flat. It's as if the prostate doesn't care how much high testosterone it's seeing. And actually this makes sense because testosterone and many hormones work through their actions via receptors. So these are 3 lobes of the rat prostate. And what we're looking at here is the binding of tritiated, this is an androgen here that's used in studies, doesn't bind to SHBG, so it's useful for these studies. And here's the free concentration. If you look at the specific binding, okay, what you see is that as the concentration of this androgen increases, the bound part to sex hormone binding globulin goes up, to the androgen receptor, not SHBG, goes up very quickly at the beginning and then plateaus. Goes up very quickly at the beginning and then plateaus. Goes up very quickly and plateaus. Once you get to a very low number here in the rat, which is about 2 to 3 nanomoles, which is the equivalent of about 60 to 90 nanograms per deciliter in men, pretty low, we're done. There's no more binding. In humans, the number is closer to about 250. And so from this, we came to the idea of the saturation model. In the past, we thought if this is prostate cancer growth and this is serum T, we thought that the higher testosterone went, the more there was growth, and it went on upwards and upwards to infinity. But in fact, it looks like it really plateaus in here. And so it's true that prostate tissue, cancer and benign, needs androgens for maximal growth, but it's satisfied its ability to use that nutrient, if you will, at a pretty low concentration. And so at some point here, this is within this range here, we have variable dependent growth, more testosterone, more growth. This is prostate cancer, PSA. But at some point here, it stops mattering. And this is a nice cartoon that's stolen from Tyndall and Ripmaster. So imagine this is a prostate cell or a prostate cancer cell. Testosterone enters the cell, is reduced to DHT. DHT binds to the androgen receptor. And then the complex gets translocated to the nucleus where it binds to androgen response elements and tells the cell to do whatever it needs to do that's androgen sensitive. But notice that it's not testosterone alone coming in. It's not DHT alone coming in. It's not even the androgen receptor alone coming in. It's the complex that's doing it. And we only have so many copies of androgen receptor per cell. And once these are all bound, adding in more testosterone can't influence this mechanism anymore. So in some ways, you could say this is one of the molecular bases for the idea of saturation. And here's a nice naturally occurring model from Mario Maggi's lab, 3,000 men seen for sexual dysfunction. And all he did here is plot total testosterone against PSA, and he's got this beautiful saturation curve right here, which again, it comes in around 8 nanomoles per liter, which is around 240, 250 nanograms per deciliter. I like to think of this as a flower, as a plant in water. Imagine that testosterone is the water and the plant is the prostate cancer. If you deprive the plant of water, it will shrivel, it will lose mass, it will lose volume. If it's still alive at this point and you water it, it'll grow. But once it has enough water, you could have a garden hose running into this house plant 24 hours a day, and that house plant will never grow to be the size of a sequoia tree. because it's used whatever it can use from its growth from that nutrient, if you will. So saturation model is that at very low testosterone levels, there's exquisite sensitivity of prostate cancer to changes in testosterone. That's why you guys are trying to get, in the guys who need androgen deprivation, lower and lower testosterone levels. But we have minimal or no sensitivity to changes at higher testosterone. The androgen receptor becomes maximally bound with androgens at a pretty low androgen concentration. And when we do large increases in serum T, it even turns out, based on work by Lenny Marks at UCLA, that even the rise in serum T is not corresponded with rises in intraprostatic androgens. It appears there's some local homeostatic mechanism as well. And I just want to show you, actually I'm going to skip this one because I think we're running late on time. I'm going to skip this one as well. Are higher T concentrations associated with increased risk of bad actors in prostate cancer? And the answer is no. As a matter of fact, higher Gleason scores are associated with low testosterone levels. Here's one study, and there are several like this. This is low-grade prostate cancers, Gleason 5 or less. We don't see this much anymore, but this is 2001. Gleason 6, 7, and 8 and above, these are mean testosterone levels. And you can see that the Gleason 8s and higher have low levels of testosterone compared to better behaved tumors. What do we find in terms of pathology, stage, prognostic factors? This is from Andrea Salonia, who works with Montorsi in Italy. In Milan, 673 men underwent radical prostatectomy. They had their blood obtained the day prior to surgery for testosterone, and low levels of testosterone, defined as less than 300, were associated with a greater than 50% increase in high-grade Gleason score and a 91%, almost a doubling, increase in seminal vesicle invasion. And men who had extremely low testosterone had a threefold increase in seminal vesicle invasion. So it's not high testosterone that's associated with bad prognostic features. It appears to be low testosterone. In fact, we have a number of items that are associated with low testosterone and prostate cancer risk. We have higher Gleason scores associated with low testosterone, advanced stage at surgery. There's data increased risk of recurrence after surgery and decreased survival, all reviewed in this paper here, sort of a master's review in European urology. Interesting, for those of you who have patients on active surveillance, we put these data together from our group, just looking at what factors would predict progression, 154 men, and the two things highlighted is prostate cancer family history. That makes sense, right? Hazard ratio of 2.3, but a very low free testosterone was also predictive of progression. Low testosterone may be the issue, not high testosterone. So the paradigm has shifted. We know there's really no evidence that high testosterone causes prostate cancer. Low testosterone is not protective. And the current evidence is really consistent with a saturation model where at very low concentrations there's clearly an impact on prostate cancer, but higher levels appear not to be. And we're now worried, I'm worried, about low testosterone in men. And so one of the things, just to go back to what Neil was talking about with this hypogonadism screener, is that I think it's men with low testosterone who need to really be watched and looked out for in terms of their prostate cancer. If they have it, the chances of them having a worse Gleason score and worse outcomes, I think, is real. I think